بسم الله الرحمن الرحيم. This lecture will be about how to interpret mammography. It will be basic more than advanced for interpretation of the mammographic views. Breast imaging will include mammography, ultrasound and color Doppler. Galactography is an underused procedure and not done nowadays. And then we have the MRI, the CT and scintigraphy. And we have also the advanced mammographic techniques on the digital mammography like contrast enhanced mammography and tomosynthesis. Regarding mammographic interpretation, we have first to know the composition of the breast. Whenever one first see the mammographic image, we'll see that it's all about linear strands inside. But what is the detailed examination of these findings and how we see it on mammogram? On mammography, we can see 1 to 2 millimeter nodular densities, which is corresponded to the SNI. This is the terminal ductal lobular unit, which is the functional unit of the breast. This is the ducts, and this is the ductules, and here are the SNI in the end. So this SNI will appear as 1 to 2 millimeter nodular densities, provided that the individual units are outlined by adipose tissue. Sometimes when the breast is very dense, you can see that it is homogeneous density of the breast. And this silhouette of the terminal ductal lobular unit may represent a wide variety of functioning or involuting terminal ductal lobular unit. Functioning, as in cases of young female with still functioning glandular tissue present, excessive, which will appear that more hypoechoic, as we will see in ultrasound and on mammography. Or involuting, and this occurs with age, and also there is aberration of the normal development and involution. What we name the proliferative breast disorders, including the fibroadenosis, the fibrocystic breast disease, this all, I like to term them aberrations of the normal development and involutions. Where is the terminal ductal unit? This is the galactography that we say that it is not used nowadays. But here, this is the image of galactography where we can see the terminal ductal lobular unit. This is the duct, and this is the ductule, and ending in the nodules, small nodules, which are the SNI. Go back to the mammography, you will find these are the SNI, and this is the linear ducts. So these are the linear ducts, and this is the SNI. So this is the terminal ductal lobular unit that we see on the mammogram. So the mammogram is not only lines, no, it is the terminal ductal lobular unit with different grades of seeing it according to the density of the breast. This is the normal anatomy of the breast. This is the nipple areola complex. This is the nipple, and this is the nipple areola complex, and usually the areola is slightly thicker than the rest of the skin. If we see that the skin of the breast is about 1 to 1.5 millimeter, but it is about 2 millimeter in the retroareolar region. And this is the subcutaneous fat, and this is the retromammary fat, and in between is the fibroglandular tissue. This is the fibroglandular tissue of the breast. You see here, this is the fibroglandular tissue of the breast. Here also we can see lines coming from the fibroglandular tissue to be attached to the skin, and this is the Cooper's ligaments, which maintain the normal architecture of the breast. The breast is a soft jelly-like structure, so there is something to maintain its shape. So this is the Cooper's ligaments, and it is important also in detection of tumor infiltration. And this is the pectoralis muscle, which must be seen on our film that the position is good. This is the inframammary fold, and here is also the pectoralis muscle on the craniocaudal view. And then when we start to interpret the mammographic image, we can post to the image in a mirror image appearance. This is the mirror image in order to see any discrepancy between the two sides. This is the craniocaudal view, and this is the mediolateral oblique view. Again, this is the normal fibroglandular tissue. These are the Cooper's ligaments. This is normal skin thickening. When we try to see the nipple and areola, especially on digital mammogram, you can just lower the window slightly in order to see the nipple and areola in a good way. Here there is the retromammary fat. It's the no man's land. We must here don't find any glandular tissue. If you find any asymmetric opacity in that area, just you must take care. So we have mirror image in order to interpret the findings, and then compare similar areas on both sides. Like this nice twin, they are so symmetrical. And then you must be oriented also with the pathology coming from the breast and from where. In order to know pathology and anatomy, you can diagnose the findings. Here we have the acinine. What is coming from the acinine? Fibroadenoma and fibrocystic breast disease. This is the breast lobules. Coming from the breast lobule may be lobular carcinoma. And then the most common, the ductal cancer, coming from the ductules of the breast. And then you can find ductectasia. This is the lactiferous sinus, which is normally, you see here that the lactiferous sinus slightly dilated. Don't measure the duct in the lactiferous sinus and say that it is dilated. You can measure the duct away from the lactiferous sinus. Also, the nipple have many diseases like Paget. The most common is Paget disease of the nipple, but there may be eczema, there may be retracted nipple due to underlying pathology. So we must look well on the nipple. We have also the fat and connective tissue. You can see breast lipoma, where the patient feel as a soft tissue lesion in the breast. Phylloi tumors coming also from the stroma of the breast. We have lymph nodes. Lymph nodes either will be secondary to a breast disease, or there may be primary lymph node affection, like in cases of lymphoma. You may find malignant axillary nodes just due to lymphoma, patient having lymphoma. So we have many diseases, systemic diseases can affect, as it can affect the lymph nodes in any part of the body, it can also affect the lymph nodes of the breast. We have the pectoralis muscles and the intercostal muscles in the ribs. We have a case that it has called abscess of the rib and the patient presenting as a breast mass. So you must be oriented with all the anatomy and pathology in the breast. Factors that increase the breast density. This is the different breast density. Here is the glandular tissue less than 25%, mean 25 to 50%. Here glandularity from 51 to 75 or more than 75. Here are the different breast densities, and they have different terms in your description. If it is fatty breast like that, and in the recent changes, we depend not only on the percent, but we depend only on the heterogeneity. It may be less than 50%, but it is markedly heterogeneous, so you can put it in C. We put it A, B, C, D. Many changes, many factors increase the breast density, like hormonal replacement therapy. In pregnancy, the breast density increase, but in pregnancy we do ultrasound only, not mammo. In lactation, weight loss due to reduction of the breast fat, breast cancer, especially inflammatory breast carcinoma, can increase the breast density, and inflammation. All those can increase the breast density. Then we came to how to standard report of the breast. First, you must write the indication that the patient coming with. If she has breast mass, if she has discharging breast, if she has palpable breast lesion, all this should be written in the indication. And then you have to put the breast composition. The composition of the breast, it is fatty or scattered glandular tissue or glandular breast or markedly dense breast. Important findings, you should put presence of mass, asymmetry, architectural distortion, calcifications, and associated features like skin thickening, for example. And then comparison to previous study. If the patient has previous study, if she's doing screening and we have newly developed asymmetrical lesion, we can see the previous study. If the patient is on chemotherapy and we want to know the tumor is regressing or not, you must go back to the previous study. And then you put your final assessment category. What is the PIRADS of this lesion? And we give management recommendation. If you recommend that wire localization and excision, or you recommend biopsy, you must put a hint to the clinician about the recommendation you want. And sometimes you find the pathology is not compatible with the imaging findings. Insist to go back to the clinician and communicate for unsuspected findings. For example, sometimes biopsy is taken from the necrotic area, and so it will be fat necrosis, although the patient has malignancy. So if you're sure of your imaging findings, please re-communicate with the clinician and the pathologist again. And this is the PIRADS classification. 0 needs additional imaging for prior examination, or prior examination is needed. Recall for additional imaging, and mainly it is ultrasound. This is, you can give PIRADS 0, and usually in the completely dense breast, better to do ultrasound examination and not depend only on the mammogram. PIRADS 1, negative on routine screening. 2, benign. 3, probably benign. Probably benign means that the rate of malignancy is less than 2%. We have to do short interval follow-up. If suspicious, it must need tissue diagnosis, and here we put it as PIRADS A, B, C, according to the level of suspicion of malignancy. But in the new categorization, we can put 3 and take biopsy if we have very mild suspicion. Highly suggestive of malignancy, we need tissue diagnosis, and this is in 95% is malignant. If a case with a known biopsy and on follow-up, then we put it PIRADS 6. We have lexicon for each modality. The mammography lexicon is entirely fatty breast composition, and this is the terms that we use to describe. Entirely fatty breast, scattered area of fibroglandular density, homogeneously dense breast which may obscure the masses, extremely dense breast which lower the sensitivity of mammography. In the presence of a mass, you have to see the shape of the mass. Is it oval, round, or irregular? The margins of the mass, circumscribed, obscured, microlobulated, or indistinct. The density, is it fat density or low dense lesion, equal or isodense lesion, and highly dense lesion. With the increase of the density of the lesion, it is more with malignant masses. Asymmetry. Asymmetry have different values: global, focal, and developing. Architectural distortion, distorted parenchyma with no visible mass. Presence of calcification, the morphology of calcification is very important. Is it suspicious calcification or benign? The typically benign calcifications, this is the malignant type, and there is typically benign calcification. You have also in the calcification to report what is the distribution of this calcification: diffuse, regional, grouped, linear, or segmental. Associated features: skin retraction, nipple retraction, skin thickening, trabecular thickening, axillary adenopathy, architectural distortion, and calcification. You must report also. And this is the recent changes on the mammographic lexicon. Minimal change in the shape. They the same. They just change oval and round, and they omit the lobular type. In the margins, they reordered the microlobulated and obscured margins. They made the obscured margin first and then the microlobulated pattern. And here they omitted the radiolucent, and it is fat containing. It is fat containing lesions. This also the other associated features, the location of the lesion. Regarding the location of the lesion, they added specification of laterality, quadrant and clock face with distance from the nipple. I always used, you must report the distance from the nipple, especially in the small lesions detected. Here is the ANDI, the abnormalities of development. This is the appearance of fibroadenosis. I put it here with the figure. This is the normal ductal lobular unit, and this is the ductal lobular unit with fibroadenosis. It's just proliferation of the normal, abnormal proliferation of the normal. Okay, when to say like this is an intramammary node. Note here, this is the fatty hilum, and this is the intramammary node. We will see on later films. This adenosis, when to report adenosis? Not all mottled breast adenosis. If you have mottled breast and the patient has no complaint at all, then it is normal. Then it is normal since there is no architectural distortion and there is no abnormality. If the patient is young age, the appearance may be like that. Here is the markedly dense breast. This is also fibroadenosis, and this will depend the proliferation was in the glandular tissue or in the stroma. If the proliferation in the stroma, it will be homogeneous density like that. If it is in the glandular tissue, we'll find this. This is the nodular, the acini. This is the nodular pattern I tell you before. But each line is go in its place, and there is no distortion, there is no retraction, and there is no bulge. Then we came how to describe mass on mammography. A mass is a localized collection of tissue. You find a collection of tissue, localized collection of tissue. Then when we found a mass on mammography, how to describe? Characteristics of the mass regarding the shape is smooth, well-defined lobule is usually benign, but the ridged edge can be malignant. So this is a rounded oval, and this with benignity. Of course, there is exceptions, but mainly those are with benignity. The irregular mass is with malignancy. And then the margins. What are the margins? The margins is the interface between the mass and the surrounding glandular tissue. Characterization of the edge or transition between a mass and the surrounding normal fatty tissue. What is the transition here? Here, this is a well-circumscribed mass. Better to don't say well-defined, because the irregular mass is well-defined, but here it is well-circumscribed. I see the edges of the mass very well, means that there is no infiltration of the surrounding parenchyma. Obscured margin, that there is margin I couldn't see, either due to dense glandular tissue above it, or there is infiltration of the parenchyma at that level. Microlobulated outline, and this also with malignancy, more towards malignancy. Indistinct margins and speculated outline. This is the speculated outline. The density of the mass, and this is very important. Regarding the density of the mass, the degree of X-ray attenuation is defined relative to the expected attenuation of an equal volume of normal glandular tissue. Look according to the normal glandular tissue. If it is so low like the fat density, you can see that it is similar to the fat of the breast. Here it is isodense to the breast parenchyma, and most benign lesions are isodense to the breast parenchyma, that sometimes when the breast is dense, we couldn't delineate the mass from the surrounding parenchyma. And then highly dense lesions, and this is more with cancer. And this is applied from our physics, from the X-ray attenuation. The malignant lesions, they are many compact cells, so there is X-ray attenuation on the lesion, and even on ultrasound you found that there is posterior shadowing due to the marked attenuation of the sound waves on this gritty mass. Stellated lesions or asymmetrical density, the majority of them are malignant. In 95% of cases, they will be cancers, in most cases invasive ductal, invasive lobular, and tubular carcinoma, but take care that a small percent are not malignant, like radial scar, like traumatic fat necrosis, and very rarely granular cell tumor. This is a mass. Here, it's not so apparent. It is obscured by the density of the breast, but still I can see that there is speculations. There is bulge here of the parenchymal cone of the breast. So here I suspect speculated mass, and when we do magnification, the mass is apparent here and the speculation is seen. But this is a malignant mass, very large in size. It's like an elephant. So we have here malignant mass, distinct central tumor, and this can differentiate from the scar. When you find the central mass large, so we can differentiate it from the scar where only speculations and the central mass is isodense of low density, so we can differentiate between scar and mass. The dense spicules radiating in all directions. The spicule length and size is very important. Spicules may reach the skin or muscles, causing retraction and localized skin thickening. We have also secondary signs of malignancy, like this is the areola is thickened, and here there is nipple retraction, and we have here marked architectural distortion of the breast. What is the architectural distortion? That we found that all the lines of the breast are attached to this lesion. So these are the secondary signs. This is a stellated scar. It causes parenchymal retraction, and here there is a speculations, but there is fat entrapment sign. There's fat within this lesion, so there is no central dense mass as we see in the malignant lesion, and usually there must be a history of operation. There is no solid or dense central mass corresponding to the length of the spicules present. We can differentiate between the stellated scar and the mass. Also, we have other indirect signs to detect abnormalities in dense breast, and these abnormalities are very important. What are the indirect signs? The indirect signs we have here, this is the normal breast cone or the normal parenchymal contour of the breast. Here, there is parenchymal contour retraction. It means that there is something here retracting the breast. Like that. This is the tenting of the parenchymal contour. We have here tenting of the parenchymal contour, ensuring that there is a mass here but obscured by the breast density. We have to do ultrasound, and this is an indirect sign of malignancy. And the presence of microcalcification. Later in the slides, I will show you the different patterns of breast calcification. This is here also parenchymal contour retraction. And this is here. I could not here see that it is a mass, but it's even asymmetry, focal dense asymmetry, and there is parenchymal contour retraction here. Diagnostic criteria for the analysis of the lesion again. Contour analysis. Here it is macrolobulated lesion, well circumscribed, and also there is a sign also here. This is the halo sign. Note here it is sharply delineated around the lesion, and this halo sign is suggestive of benignity also, but still we have less than 5% maybe malignant. Regarding the density of the lesion, diagnostic criteria for analysis of circular and oval shaped lesion. The density may be radiolucent or fat containing according to the recent criteria. Like this. This is a fat containing lesion. Note here the density of the lesion regarding the fat of the breast. This is the density of the lesion, and this is the fat of the breast, and there is a thin line around, so this is an oil cyst. Lesions with mixed density and lesions radio-opaque or highly dense. Although circular or oval lesions are with benignity, but we have a differential diagnosis of well-circumscribed masses like medullary carcinoma, sarcoma, intracystic tumors. Therefore, the density of the circular lesions has to be analyzed. If you find any interruption of the normal lexicon, you have to make biopsy. Okay, let's take a hint or a practical example on this talk. Here we have, this is breast. Here it's not so good technique. This is the pectoralis muscle, but the pectoralis muscle here is not seen. This is homogeneous breast density, but here, is there any abnormality? Sometimes if you are not so specific, you do not change the window, you will miss the lesion. But here there is a lesion here. How can I know this is lesion? It's more dense or isodense to the parenchyma, and here there is a halo sign. This is the halo sign that we say before, and moreover here there is a slight contour bulge of the breast at this area. This is in the mediolateral view. Here is also, this is a slightly dense lesion. Here, when we change the window, here is the circumscribed mass with thin halo sign. And so here from the criteria of mammography, we can say that it is benign. In all these lesions, we don't give pyrites 2 at all. Even if we're sure that it may be fibroadenoma or cystic lesion, please, you must do ultrasound and give it pyrites 3. Here, this is the lesion on mammography, on ultrasound. And there is still on ultrasound, it may look like benign lesions, but unfortunately, there is metastatic axillary nodes, and so this is pyrites 5. Another case, here is the mammography, homogeneous parenchyma, and here is a comet tail of the breast. So although the lesion is well circumscribed, but it is obscured in part with a tentacle coming from this lesion. So it is suspicious and needs further examination by ultrasound. So it is fairly well defined, rounded mass seen in the upper outer quadrant with an ill-defined posterior border. Having a long tentacle, long thick tentacle, which you may say comet tail appearance. And here is the ultrasound with fatty content in the hilum, and this is malignant lymph node. And as we say before, that the lymph nodes may be coming secondary from breast lesion, or it may be primary lymph nodal disease like lymphoma. So this is what was a case of lymphoma, and the patient has other lymph nodes affected in the cervical region, many lymph nodes. And when you find isolated lymph nodes in the axilla, you must go up to the neck and supraclavian region in order to detect other lymph nodes in the area. This is another case. This is a mass, and this is the ultrasound appearance. From the mass, it is rather well circumscribed, but if you see here that there is calcifications, there is crushed stone appearance. This is calcification, so there is a solid part here. This margin is obscured, and when you see on ultrasound, there is a solid mass inside this cystic lesion with high vascularity and infiltrating the parenchyma at that area. So this is an intracystic carcinoma. This is a case of cystosarcoma, and there is also infiltration of the parenchyma here, as we see, this large mass, and there is speculations around, and there is distortion of the parenchyma at this area. The fibroadenoma is the most common benign tumor, and this is different appearance of the fibroadenomas on mammo and on ultrasound. Note here the fibroadenoma is isodense to the breast parenchyma. It is isodense to the breast parenchyma, although the breast here is fatty. And on ultrasound, it has many criteria. I will give you, inshallah, a lecture on breast ultrasound, diagnostic criteria in breast ultrasound. Here is the multiple, mostly fibroadenoma may come multiple, well circumscribed, isodense to the breast parenchyma, and sometimes it shows popcorn calcification, which is specific to fibroadenoma, involuted type. This is another one. This is a large one, well circumscribed, and there is a halo, but we must do ultrasound, as we say. The ultrasound either low down the grade, if you put it here, PIRADS 3. On ultrasound, if it is solid, then it is 3, and with follow-up. If it is cystic, then we put it PIRADS 2. This is 2 from the start. This lesion is 2 from the start. It is very isodense to the parenchyma, and it shows starting popcorn calcification. So this is an involuted fibroadenoma. We can put it PIRADS 2. Breast cyst. Breast cyst can be seen on mammography and cannot. Here, this is a breast cyst. It's very isodense to the parenchyma, so it can be obscured. We can see it on mammography. But here we can detect that there is contour bulge here in the parenchyma of the breast, and it is a breast cyst, as we see on ultrasound. Radiolucent lesions. What are the different radiolucent lesions? The oil fills in the circular adipose tissue or oval-shaped lesion. We have lipoma, the lipoma of the breast. This is a lipoma of the breast. How can we know that it is lipoma? It is a space-occupying lesion. It spread, the parenchymal tissue is surrounding this area. The parenchymal tissue is seen surrounding this area. It's low, similar to the breast fat. So this is the typical appearance of breast lipoma. Oil cysts also contain low density. This is the oil cyst with a marginal rim here, and there may be calcification. And usually the oil cyst is part of the fat necrosis or the first spectrum of fat necrosis. Fat necrosis may be due to surgical interference or may be due to trauma, mild trauma, and the patient could not see, and we found many cases of oil cyst and the patient didn't give history of trauma. We have also the galactosele and the fibroadenolipoma. So we have lipoma, we have oil cyst. This is the fibroadenolipoma, but the fibroadenolipoma or the hamartoma is a lesion of mixed density because it's not all tissues radiolucent. There is a dense tissue and there is lucent tissue surrounding. So this is a hamartoma of fibroadenolipoma. This is also a galactosele with fat fluid level. Here, this is a galactosele showing fat fluid level, and usually the fat of the milk will be upwards. So this is a fat fluid level galactosele. And then the lymph node. This is the lymph node. This is the axillary, but we may find intramammary lymph nodes also. There is a lucent fatty hilum, and this is the cortex of the lymph node. Then we came to the asymmetries. Asymmetries findings that represent unilateral deposits of fibroglandular tissue not conforming to definition of a mass. I found that there is asymmetry, but I couldn't say that it is a mass. Asymmetry may be seen in one projection and may be seen in two projections. So we have different types of asymmetry: focal asymmetry, global asymmetry, and developing asymmetry. Here is the focal asymmetry. As we say before that, you usually see the breast in a mirror image. So when I compare the two sides, I find that there is a lesion here not found in the other breast. So this is focal asymmetry. But the focal asymmetry here, there is no distortion, and it is very similar to the parenchyma of the breast, but better to do ultrasound. Global asymmetry, you find that this breast as a whole have increased density than the other breast. So this is a global asymmetry and not focal asymmetry. Usually the global asymmetry we find more in inflammatory breast carcinoma and inflammatory lesions of the breast, or even in breast edema due to systemic cause. Asymmetrical density on mammogram, the vast majority of asymmetrical density consists of normal breast tissue. This is an accessory breast. This is asymmetry. When you look on the other axilla, there is nothing, and then you find here an asymmetrical density. And this is an accessory breast, and usually the accessory breast have the same density as the normal parenchyma. So this is an accessory breast. Asymmetrical involution, and we see this in old age. We can find that an area, the whole breast become involuted, but an area still present with no involution. Hormonal effect in the premenopausal age, or a patient taking exogenous estrogen. Post-traumatic and post-inflammatory also may cause asymmetric lesion. This is asymmetrical involution. This is an area of asymmetrical involution of the breast. This is a perimenopausal age patient. There is here asymmetrical density compared with the other side, so this is asymmetrical involution. There is also asymmetry, but this is not as asymmetry without distortion. It is asymmetry with distortion. Note here there is retracted nipple, there is tenting of the skin, there is skin tenting here, and there is mild speculation seen in this lesion. So this is a malignant mass seen retroareolar with indirect signs of asymmetrical density, of course, and then secondary signs of retracted nipple and tenting of the breast towards this lesion. Asymmetrical density with architectural distortion. Again here there is asymmetry with architectural distortion. Here, if one want to say that it is a mass with indistinct borders, that's okay. If you say that it is focal asymmetry, no problem. Here there is also focal asymmetry with architectural distortion, and this is mostly with malignancy. The edematous breast. Then we came to the edematous breast. What are the mammographic features of edematous breast? We found that global asymmetry. If you put the other film, you will find global asymmetry. You find thick skin in the lower, mainly in the lower part due to gravity. You find the edema mainly in the lower part of the breast, and when you find the edema upper, you can say that there is a lesion in the upper part distorting the, like inflammatory abscess here, it can do that. Diffuse increased density, coarse trabecular outline, and it looks like the interstitial lung edema, and breast enlargement. These are the signs, and then you start to detect the cause. In this case, the cause is seen in the film. There is a speculated mass here in the axillary tail which caused this edema. Don't forget to look on the nipple. The nipple is very important. You must localize on the nipple. If you find the nipple is enlarged, you must look at it well. This is a case where there was nipple enlargement and there's focal lesion here. And on doing ultrasound, it was just, of course, it was seen on the surface of the nipple. This is the case with the surface of the nipple. This is a nipple mass here. And there is vascular pedicle sign like any papilloma. There is vascular pedicle sign, and this is a mass on the surface of the nipple. Of course, it was seen by the naked eye, but what is adding the ultrasound, it is only in the upper part and no ductal extension. There is no other lesions present. This is a retracted nipple. This is a retracted nipple. And also the retracted nipple is pirates too if there is nothing. And especially you can ask the patient if it is congenital from the start or it is recently retracted. And you must look also on the ultrasound. You must be sure that there is no retroareolar masses seen, especially in the mammography is dense. And this is the appearance of the retracted nipple on ultrasound. Then we have the recent techniques. I will just give a hint because this lecture is mainly basic. Breast tomosynthesis, if you get better interpretation of the mammogram with the ultrasound, you will not be in need of the further advanced investigations, but it aid in the diagnosis. Like breast tomosynthesis, what is the breast tomosynthesis? It is multiple low-dose exposures taken at different angles. And these images are then processed to make tomographic slices. We take tomography of the breast. The appearance, we have here two cystic lesions or well circumscribed masses seen here, and they are better delineated on tomosynthesis. And then we have also the contrast enhanced mammography, and this also can improve the resolution and detection of the mass, especially in dense breast, and in the extension of the masses, in knowing it has many good indications. And here there is a mass, but here we can detect from mammography. Here there is contour bulge, and there is a speculation in the upper part, and there is the mass taking enhancement in the contrast enhanced mammography. This is also a case, focal asymmetry. But here taking ring enhancement, so it's not a malignant lesion, although it is speculated. So this is an abscess cavity. Diffuse breast edema, global asymmetry of the breast, but there is bilateral breast edema here and there. And there is asymmetry here, diffuse asymmetry of the left breast, global asymmetry of the left breast. And we have also focal asymmetry in that side. And that's the contrast. And we have two different patterns. Intense contrast enhancement of diffuse carcinoma of the left breast. And here we have a benign looking lesion, which is fibroadenoma on the right with stranding. Here it may be looking like the hamartoma on the mammography. Well defined with internal septations. So we have fibroadenoma on one side and diffuse carcinoma on the other side. Another lesion, focal asymmetry. Note here the focal asymmetry. I want you to concentrate on the mammo. So this is here a focal asymmetry with distortion, and here it takes heterogeneous enhancement on the contrast enhanced mammogram. And this is the MRI of the case. So this is intraductal carcinoma grade 2 with accurately seen on contrast enhanced mammography. Here there is also two enhancing lesions present. Here, if you go back to the digital mammography, you will find that here there is a speculated lesion present with a speculated outline, although obscured by the parenchyma, but you can detect there is architectural distortion in that area. Here also they are enhancing malignant axillary nodes on contrast enhancing mammography. And then we came to the last modality that we can see in the breast. This is the PET scan. Nowadays there is PET mammography. I think it will be better than the full PET scan. But here you can see that this is a dense glandular breast, and the dense glandular breast can take diffuse uptake in the PET scan. So this is not an abnormality, but if you found a focal lesion seen, you can see it, although the PET scan is not used for primary investigation of the breast, but usually we use it in the follow-up of cases. Okay. This is an MRI. We will not go to the MRI of the breast in this lecture. because it is, I want to be more basic. So here, just remember the 5 rules to be happy. Free your heart from hatred, free your mind from worries, live simply, give more, and expect less. Then, this is the breast edema. There is marked increased density of the breast, and that we give PIRADS 0. This is PIRADS 0, because we could not see anything else. So we have here marked increased density of the breast parenchyma associated with skin thickening and obliteration of the subcutaneous fat, so we have to do ultrasound. And this is the ultrasound appearance, and this is very characteristic appearance of breast metastasis, that we found subdermal multiple well circumscribed masses. This is the markedly thickened skin, and this is subdermal multiple masses present below the skin. This is the appearance of breast metastasis. The breast metastasis occur in 4% of cases, so don't miss, usually from adenocarcinoma or malignant melanoma, and this case was an adenocarcinoma metastatic to the breast. There was axillary nodes, and there was, because it's blood spread, it come also subdermal in location, so this is a case of breast metastasis. Here also breast edema, but what is the criteria of breast edema in this case? Here we have, this is the breast, and there is skin thickening, but the skin thickening here is not with gravity, it is just up, so this is focal skin thickening in the upper part of the breast corresponding to these breast abscess. So this is a focal skin thickening corresponding to breast abscess, so take care, is the skin thickening diffuse or focal? And the axillary nodes here. This is another case. This is completely free breast. Scattered glandular tissue, ACRB, normal skin thickening, normal nipple areola complex, but we have this problem. We have multiple malignant infiltrated lymph nodes, bilateral. It's dense lymph node, no fatty hilum or eccentric hilum as in this case. So these are malignant axillary nodes, and this is a case of malignant lymphoma of the lymph node of the axilla. This is another case. We have here a well circumscribed lesion in the left breast. Here there is another lesion, another lesion, another lesion, but even the well circumscribed lesion have an obscured margin in part, so it's not totally benign, and it is markedly dense. And we have other lesions with speculated density here and there, so we have multicentric malignant process. I just put this slide to show you the difference between the low density lesion like that and the high density lesion like that. This is a low density lesion. What is this? This is just a dilated duct with proteinaceous secretions inside, so it is of low density. This is a dilated duct, and this is a speculated mass here, so we have bilateral malignant processes, and this density is just a dilated duct retroareal. Of course, malignant. Is it benign or malignant? Of course, it is malignant. We have here all the primary and secondary signs of malignancy. Dense mass, dense mass, surrounding architectural distortion, nipple retraction, skin thickening, areolar skin thickening, there is no diffuse skin thickening, and there is also an intramammary nodes here. We don't know they are infiltrated or not, you must do ultrasound. So this is a malignant mass with all criteria, primary signs and secondary signs. And this is the mass by ultrasound. It is irregular outline, thick echogenic halo surrounding it. And here also, what's your PIRADS in this case? We have here a mass. This is a mass with a speculated outline, architectural distortion, Focal skin thickening on the mass means that mostly that the mass is attached to the skin. And then we have also secondary signs. We have malignant axillary node. You can see here the difference between the benign axillary node and the malignant axillary node. It is more globular, eccentric hilum, and more dense. But here the hilum is preserved and the cortex is thinned out. And this is the another case with ultrasound. And this is thick eccentric hilum of the lymph node. But all this I think she's older in age because there is a young age because there is diffuse dense breast. And here we have well circumscribed mass, but you must pick this. It's not all the way well circumscribed. There is a speculated area here. So we must take care. And this is the lesion. It is a well circumscribed mass, and this was a case of cystosarcoma phylloid tumor. This is again axillary node looking malignant. In a patient doing mastectomy, we must know if it is metastatic or there is another malignant lesion in the same breast. From the mammogram, I think here there is focal asymmetry in that area. Here. And on ultrasound, there is another malignant mass in the other breast. And malignant axillary node that we see on mammogram. This is a very large axillary node with marked vascularity. Note in the malignant node you found the vascularity is coming from the cortex and not from the hilum because it is infiltrated. So it is 5, of course. This is a case of a female patient with left conservative breast surgery. If I put these films and I didn't say the history in this case, could you pick? Yes. There is a small size of this breast compared to the other. There is diffuse skin thickening, and the skin thickening and edema in the post-therapeutic breast can be found even all the time after. So there is edema, trabecular pattern, skin thickening, but still we have to do ultrasound in order to see that if there is recurrence or not. And here there is skin thickening and there is a mass here in the breast, and these are the lymph nodes, and she has also supraclavicular lymph node. Is this lesion benign or malignant? Again, it is malignant. There is nipple retraction. There is speculations. There is an intramammary node here. And this, we say before the signs of malignancy. Of course, this is fibroadenolipoma. This is the typical hamartoma of the breast. In the hamartoma of the breast, we say that it is breast within a breast. This is breast within a breast, as if you see there is fat and this is glandular tissue. So it is termed breast within a breast sign. So this is hamartoma pyrades 2. This case was put as normal finding pyrades 1, but her problem that she has a mass. She's coming with a firm mass in the breast. And then there is very subtle asymmetrical density here, replacing the retromammary fat, replacing the surrounding retromammary fat. And on doing ultrasound, there is a rib distortion here, and there is associated cold abscess Potts disease of the ribs. And of course, we do MRI, find that this abscess coming from the and unfortunately the patient has many others. This is the mass in the breast, but she has also spinal cold abscess, but she didn't know that this mass is a part of this pathology. So always think of systemic diseases that may affect the breast. Another case, here there is a dense breast, markedly dense breast, and this breast show nipple, show mild skin thickening. There is a lesion here. And this is a mass with axillary metastatic lesion. This is a mass, right bulbable retroareolar lesion. You must pick another finding which is more important. This is well circumscribed lesion, retroareolar, and here there is a speculated lesion with tenting that I said before. So here there is a retroareolar mass on the right side, intracystic carcinoma, and unfortunately the patient has another mass in the other side. If we return back to mammography, this is the lesion. So she has double malignancy. So don't be entrapped. And here is the classical microcalcification, malignant microcalcification. Here they are clustered. This is clustered microcalcifications with this parenchymal contour retraction. So you have here the two indirect signs we say before, the parenchymal tenting and the associated microcalcifications. Here is the pleomorphic, clustered pleomorphic microcalcifications. Clustered pleomorphic microcalcifications. خلاص بقى fibroadenoma يعني I think you exhausted the hamartoma type. Another case برضو probably malignant because there is architectural distortion. And this is how we can see the mass in the no man's land. Here this is the retroareolar fat and you see the mass here. So this is malignant mass. This is the posterior shadowing. Next we will do ultrasound inshallah. This is another mass. This is typical for malignancy also because it is well circumscribed, but there is speculations and architectural distortion. It is well circumscribed, but take care to magnify. There is speculations here and architectural distortion, so this is malignant mass. This is the mass by ultrasound. This is involuted fibroadenoma. This is also Piret's 2. And here there is scattered macrocalcification, which is also benign lesion. Definitely benign, Piret's 2. But unfortunately, the patient has another lesion beside it. So this is asymmetry with distortion, and it is malignant lesion. This is another case. Here is a lesion. Also, it doesn't look well. There is angulated border and globular in shape. So this is a malignant lesion. A patient coming with 2 weeks after the operation with this lesion. What is this? So this is a hematoma. This is a hematoma post-operative. In the early post-operative, we must not do mammography because the breast will be tender and ultrasound can help. You can see the well circumscribed mass. You can see that there is no, either it is seroma or hematoma, so you can do ultrasound just. Here this is hamartoma. Here also this is What is your pyrids in this case? This is pyrids 4, and this is scattered calcifications present, taking segmental distribution. Here there is segmental distribution of this calcification, and there is associated soft tissue density present. This is